So our next speaker is Dr. Ashley Lee. Ashley is a service urology registrar here at Fiona Stanley. She has aspirations to apply for urology training, and I hope she gets on. She has interest in the environmental footprint of urological services and creating solutions specific to the practice to create a more environmentally sustainable healthcare system. Ashley.
Thank you. And thank you for having me. And today I would like to talk to you about the 10 ways that we made our urology department more environmentally sustainable. However, no matter what brought you here today, what department you're from, medical, surgical, public health, I'm sure that there's a lot that you can take from my presentation today that can be applicable to you. And for the people that may have seen this presentation before, you'll be seeing it again, and you're welcome. So I'd like to acknowledge the Green Urology Group, which was created last year, and Jen was talking about the creation of that group and the advocacy that it involves. It's now developed into the Green Urology Network, with all urology departments in the 3 major hospitals in Perth now being involved and sharing our ideas and advocating for change in our departments on a broader scale. And I'd also like to acknowledge the head of the department, Professor Dickon Hain, as large initiatives like these require strong leadership and support. And I will be mentioning a couple of brands today, but I have no financial disclosures. Nobody takes me out to dinner. Okay, so the talk will be a bit like this. We'll talk about the reason for doing the study, the 10 steps, and the broader implications. So we're all aware that the healthcare sector does emit quite a high burden of carbon, and the public hospital sector, particularly the operating theatres, has a lot to answer for. So I have been looking into a couple of the processes that we have, and a lot of what I'll be talking about today I'll be converting into CO2 equivalents, which a lot of you will be familiar with. It's just a unit that we use to determine how bad something is for the environment, essentially. Okay, without any further ado, the 10 changes. So the first thing I'd like to talk about is reusable surgical instruments. You can see in the paper published by Rizen et al. That particularly laparoscopic instruments in the form of clipper pliers, scissors, and ports, that the reusable instruments had a much lower environmental footprint than the single use. Now, this is unfortunately not the same for reusable endoscopes, but if you have any more information on that, you can talk to me later on. The consent forms are a piece of paper that needed to be created, printed, stored, written on, only then to be scanned into the digital medical record, triple shredded in confidential waste, and then either put into landfill. So we could change this whole process by creating a digital application where patients can sign onto an app, like on a phone, and that's what we have in this hospital, the e-consent application. Now, this does bring up the issue of server energy. So the more applications that we have, the more energy that we use in keeping major warehouses full of energy inducing data collection, but that's a different story. So we would like to advocate for the e-consent. The company that we use, ShredX, does recycle the confidential waste here in this hospital, which is excellent. So in your hospitals where you're from, where does your confidential waste go? Our multidisciplinary team meetings Jens was talking about earlier today, we've stopped printing, saving 20,000 sheets of paper annually. We also have been making everyone bring in their own keep cups, so there's no more cups that from the cafe. And the other thing is that we have converted, with the help of COVID actually, to teleconferencing. So people that don't have any on-site responsibilities that day in the hospital don't have to drive into the MDT. They can Teams in and be just as a contributing member of the MDT. Now, as you can see, the energy efficiency of different vehicles coming to work that day, you probably can see your car up there. So that's a saving of 3 kilograms of CO2 for a 1-person round trip attending our MDT. This is based on everyone driving an average car on the road, not driving a Lamborghini Aventador to work. Okay, so the Think Before You Bluey campaign, very successful in this hospital. Where we would use blueys quite a lot is in flexible cystoscopy in the suite, as you can see set up there. We've replaced the bluey under the patient with a cotton towel. And we've been discussing with Linen Australia that the cotton towels, the laundering of them, the water is recycled 90%. However, being cotton, it does absorb a lot of water and there's a lot of energy used to dry the towels. So there are a couple of alternatives which we can see outside. So So there's the green bluey and another alternative towel that uses less water to reprocess and has a longer life cycle than a cotton towel. So that's other options for us. We like to investigate for prostate cancer, and we have developed a streamlined process for this called the one-stop prostate clinic. The usual care model involved 3 patient visits, and with the size of Western Australia, patients were needing to fly to Perth 3 times in order to have their assessment for workup for prostate cancer. We've streamlined this, as you can see in the one-stop prostate clinic, to need only 1 or 2 clinical consultations. And this is just because we've put this together with a lot of nursing help to facilitate this streamlined process. And is there any way in any of your clinical interactions with patients that you could streamline your clinical, particularly if they're traveling long distances like we do here in Perth? This, over a course of 4 years, saved 1.5 million kilometres of travel for patients. And this equated to 440 tonnes of CO2 saved by reducing by 1 clinic. So continence surgery, reducing diapers, the war on diapers, says the wannabe urologist. So the energy intensity put into the raw material manufacturing of the diaper is immense, as well as the waste emissions and air pollution and water pollution from the diaper itself. One person wearing diapers for a year is about 7 cubic meters of landfill per year, and these things don't biodegrade. They turn into microplastics, and the dangers of that we've spoken about earlier. So from a urology perspective, we like to inject Botox into the bladder to relax it, so reduce incontinence, and I advocate for other incontinence surgery to reduce diaper use where possible, or reusable diapers that can be washed. Local anesthetic procedures over general anesthetic procedures where possible, and this is quite applicable in urology with the prostate biopsy. So looking into the energy and the waste induced in a general anesthetic operating theatre versus an outpatient setting is enormous. But if we want to focus on the inhalational anesthetics, we'll probably be discussing later on today a little bit more about the global warming potentials of desflurane, which is now not used in the South Metro Health. So the global warming potential is up to 1800, quite significantly dangerous for our environment. So you might be thinking, well, if I'm going to do a procedure on a patient in an outpatient setting, maybe I'll give them nitrous oxide. At a global warming potential of 265, it's still not the best option. May I advocate, perhaps click again, for the use of methoxyfluorine for suitable patients with a global warming potential of 4. This might be a good option for you if you need an inhalation, if you need an anesthetic, doing a local anesthetic procedure. Okay, so we'd like to encourage and enable as much rural practice as possible by sending specialists to patients, not patients to major cities. And the way that we facilitate this is by setting up clinics in Broome, Kununurra, Geraldton, and Port Hedland. And the fuel efficiency of different aircraft traveling different distances varies. So it reduces with time. So the most fuel inefficient place to get to is Port Hedland. And one of the better ones is Geraldton because it's a bit closer. So it makes more sense to send one specialist to see 30 patients than send 30 patients to see one specialist. It just makes good sense. So in terms of the calculations, if we flew to Geraldton, 160 grams of CO2 per passenger kilometre, that equates to 119 kilograms of CO2 for a 1 doctor return flight, saving quite a lot over a year of service delivery, as well as being better for patients that live in rural areas to not have to travel. Harder barriers to surgery, smoking and obesity. We know that these contribute to a lot of poor health in our patients, and particularly urological malignancies with smoking. So we like to advocate for complete smoking cessation prior to major urological operations with the help of nicotine replacement therapies, and obesity to reduce the BMI to 35 for major urological operations. And the reason for this is that patients that are either smokers or obese spend longer in hospital, and they have more complications. And this means that they might end up in the ICU. If they're in an acute bed, that makes 5.5 kilograms of solid waste a day, but 45 kilograms of CO2. And if they're quite unwell, then that's up to 138 kilograms of CO2 equivalents per day in the ICU. So This does have a bit of an advocate. We do try to not marginalize people that are obese or smoke, and we definitely help and facilitate them reducing cigarettes and reducing weight. Once you start doing things in your department, share your success with others, broadcast what you've done in like e-newsletters, departmental meetings, collaborate your ideas, which might be easily transferable onto other departments. And you can see a picture, rather pixelated photo of our department when we started not printing for our MDTs anymore, and constantly looking for improvement. So the broader implications of this is that, next please, urology is going green, and we're trying to become one of the standout services in environmental sustainability. Anesthetics is definitely running in the race there. But we are making changes to try and achieve the net zero. And what do you need to do in your practice to make the changes? Because nobody is going to give you a project. Nobody is going to tell you, just do this, it's going to be okay. You actually have to come up with these projects yourself, innovate in your own departments. A quick summary of those 10 points: reusable surgical instruments, e-consent, MDTs, towels or towels alternatives instead of blueies, streamlining your clinical consultations and your workup processes, reducing diaper use, local anesthetic over general anesthetic where possible, enabling more rural practice and harder barriers to surgery, and then encouraging others to do the same. Thank you very much. Those are my references.
That was fantastic. Thank you so much, Ashley. Certainly, as an anaesthetist, maybe it's a little bit ironic to say, but we love it when services want to take on doing more local anesthetic procedures and not have more general anesthetic procedures, believe it or not. But from a sustainability perspective and from a service delivery perspective, we know it is likely going to be better for patients.